Welcome, everybody, to the new AHA Guidelines webinar and the Evolving Consensus on Stroke Imaging. My name is Carolina Meyer, and I will be your host today. We have a phenomenal panel of speakers here. With us today are Dr. Edgar Samaniego, Associate Professor of Neurology, Neurosurgery, and Radiology at the University of Iowa. He's also the Director of the Vascular Neurology Fellowship there. Dr. Jason Tarpley, who is Director of the Stroke and Neurovascular Center, as well as the Vascular Interventional Neurology Program at Providence Healthcare System. And Dr. Greg Albers, Professor of Neurology at Stanford University and Director of the Stanford Stroke Center, as well as Scientific Lead and Co-founder of RapidAI. We're going to have some fantastic presentations, as I mentioned before. Please put your questions in the Q&A button at the bottom of your screen. We're going to have the presentation starting with Dr. Albers, who is going to talk about IV thrombolysis, followed by Dr. Edgar Samaniego, who will be speaking about mechanical thrombectomy updates relative to the guidelines. And we're going to finish off with Dr. Jason Tarpley, who's going to cover the topic of medium and distal vessel occlusions. So with that, I am going to stop sharing my screen, and Dr. Albers, please take it away.
Thanks, Carolina. It's really a great opportunity to talk about these new guidelines. My topic is IV thrombolysis, and there are some major changes in the IV thrombolysis guidelines that we will review. So let's dive in. One of the first new changes is that for early window patients, the recommendation is to treat irrespective of NIH stroke score as long as the deficits are disabling. So rather than trying to decide based on NIH score, you make a clinical assessment. If the patient has disabling deficits and they meet criteria, they should be treated. If they are non-disabled, then the recommendation is to use dual antiplatelet therapy. So this obviously means that you have to assess for a given individual what's disabling. Somebody who's a violin player may have a different level of disability from some trouble with hand coordination than other individuals. So clinical judgment is indicated. Now, another big change is that tenecteplase has now been elevated to be equal to alteplase in the AHA guidelines. So for patients who meet criteria within 4.5 hours, the recommendation is you can either go with TNK or you can go with TPA. And obviously, there's been a huge transition across the country and really worldwide to use TNK because of the more convenience of the single bolus. The recommendation is at 4 hours, despite the FDA continuing to have a 3-hour approval for both TNK and alteplase. The most interest in the IV thrombolysis guidelines, the biggest change happened with the greater than 4.5 hour patients. So that's what we'll spend most of the time on here. This is historical trials. Over a dozen trials had tried to break that 4.5 hour window barrier, but the trial that first broke it was in May of 2019. So this is really old news, but the last guidelines from AHA came out in 2019. So this trial, as well as this pooled analysis that was also done in 2019, couldn't be incorporated into the guidelines until just a couple months ago when the new guidelines came out. So this is the Extend trial, and it showed that for patients with perfusion imaging-based selection, looking for 20% or more mismatch and a penumbral volume of at least 10 mLs, that was a statistically significant benefit in the primary outcome of reaching an MRS of 0 to 1 at 90 days. Now, what was helpful for the guidelines to push this over to a 2A recommendation is that there was a pooled analysis where 2 other studies were included. This is ECASS IV and EPITHET, which were 4.5 to 9 hour TPA versus placebo studies, but they didn't use automated perfusion mismatch. They used eyeball of perfusion mismatch. So some of the studies met extend criteria and some didn't. Some of the patients who did meet the extend criteria were included here in the mismatch analysis. And when you put these all together, you can see that the odds ratio obtained here was 2.0, which compares very favorably with the odds ratio obtained in the original NIHSS 3-hour trial, where half the patients were enrolled within 90 minutes. Absolute benefit was about 10% for MRS 0 to 1, same for both trials. So it basically showed that you can take late window trials with favorable imaging and get the same type of TPA benefit that you see in early window patients. But probably the more important part of this pooled analysis is what I'm showing here, which is that there were about 100 patients, primarily from EPITHET and ECASS IV, who, when they were run through the automated software, they did not have the mismatch profile. That was typically because the infarct had completed. There was no evidence of salvageable tissue. In other words, less than 10 ml of mismatch, and in some cases, the core was over 70. But for these patients, what you could see is that the death rate on TPA was substantially higher than in placebo. The rank and 5 severe disability rate was also higher, so this was unfavorable, and there were actually fewer patients who reached 0 to 1 in the alteplase group than the placebo group. So this gives us an idea why those 12 prior trials may have failed. There's a lot of patients in the later window who have favorable imaging, but those who have unfavorable imaging can dilute out the effect of the favorable imaging patients and lead to studies being non-statistically significant. So this was consideration in the guideline that I'll show you that extends the time window for IV thrombolysis out to 9 hours. Now, in addition to that, there were some additional studies that pushed the guideline all the way out to 24 hours, but only under very restricted conditions. These were Chinese trials that had a lot of patients with large vessel occlusions who would normally get thrombectomy, but thrombectomy was excluded in these two trials. So let's take a look at them. The first was published in the New England Journal in 24. This is TRACE 3. It is TNK versus standard medical treatment, 4.5 to 24 hours in patients who could not get EVT. And I'll show you the type of patients in a minute, but you can see this was a favorable shift in the Rankin scale, statistically significant effect for a positive trial. And very similar results were obtained in HOPE, which was published in 25, and JAMA. This was alteplase versus standard medical therapy. So let's look at the type of patients who were enrolled in the studies. So first of all, for TRACE 3, you can see these are internal carotid M1 MCA and M2 MCA, the majority of patients being in the M1 MCA category. So clearly these M1 and ICA patients, if they're in the 4.5 to 24-hour window and have favorable imaging on perfusion, they would be candidates for thrombectomy per current guidelines. They were patients who did not receive thrombectomy in these Chinese sites, so they were enrolled in the TNK versus control. And you can see that the biggest benefit was actually M2 patients, smaller number of them, but the benefit of TNK seemed to be largest in this subgroup. Similarly, in HOPE, you can see it's ICA M1 and M2s. Again, the M2s have the greatest benefit. So this gives you an idea that M2 without thrombectomy in the 4.5 to 24-hour window is clearly benefiting. But these patients with M1 and ICA would not have been enrolled in the US or Europe because they would have gone to thrombectomy. So what about patients who do go to thrombectomy in the late window who get some bridging with TNK versus placebo? Well, this was assessed in the Timeless study. And what we can see is there were some favorable trends, but not a statistically significant effect. One of the limitations here is that the dwell time, the time between the TNK versus placebo injection and the thrombectomy, was very short, only about 15 minutes, so really didn't give the drug a lot of opportunity. If you look at patients who were randomized in an on-EVT site and did have a long dwell time, there was a tendency toward benefit, although there were very few patients, so not statistically significant. You also see that the M1 patients had a strong trend toward benefit, whereas these M2 patients did not. But in particular, the poor outcomes were a combination of M2 and thrombectomy. We were surprised to see that even distal M2s, the majority of these patients were getting thrombectomy in addition to the TNK versus placebo randomization. All right, so what did AHA do with this new data? They came up with a 2A, a level of evidence B, based on randomized trial data to support the extend protocol. So for patients in the 4.5 to 9 hour window, TPA or TNK, IV thrombolysis, is recommended. It's a 9 hour window, and that 9 hour is based on known onset time, or if it's a wake up stroke, you use the midpoint of sleep, and then you've got 9 additional hours for this therapy. What about the HOPE and the TRACE? Well, they said you can expand to 24 hours for LVO patients who cannot receive EVT. So if an LVO patient who is not eligible for EVT but has favorable imaging, then you can proceed with this, and they restrict this to stroke experts to analyze the penumbral imaging. So again, probably not a big impact here for the LVO patients. But right at the time when the guidelines were presented, there was a new study that came out, again from China, which is looking at the 4.5 to 24-hour patients in non-LVO patients, so patients who could not get EVT, so not planned for EVT because they have distal or medium vessel occlusions, 4.5 to 24 hours. Again, perfusion imaging based selection, similar mismatch criteria. This did not make it into the guidelines because of the timing, but it is another positive study. So you can see that there's a favorable shift, particularly for these more favorable outcomes. You can see more patients getting the zero outcome here. And the overall primary outcome of MRS 0 to 1 at 90 days was statistically significant. You can see no difference in severe disability or death. So again, this would support what was shown in TRACE 3 and HOPE, is that if you have these more distal occlusions and you're not getting thrombectomy and you have favorable imaging, there may be benefits all the way out to 24 hours, just as we've seen for thrombectomy. I'm going to stop at this point and see if we have any questions or comments.
We actually have, thank you so much, Dr. Albers. This is a fantastic summary. We do have a question here. For those extended window in the Asian studies up to 24 hours, what was the mean time to thrombolysis in those trials?
The mean time to thrombolysis in the Asian trials, again, these were long window trials. I don't remember the exact time, but it was between 4.5 and 24 hours. So I think it was around 12 hours from those trials, but I have to double check the exact number.
I think we looked at that too, Greg, and it was in all the trials, it's kind of right around 12 to 14.
Yeah.
So not super late patients. I have a comment, which is that I think you're right. It's old news, but I'm giving you the perspective of the large health system. So Providence is 52 hospitals, 6 states, and I think we're already doing it in the comprehensive stroke centers. But what changes now is I think this is a more mainstream thing now. So when someone presents to one of our primary centers that we may perform telestroke at, we need to be doing perfusion imaging at all those sites. So that's actually going to be a pretty mammoth change for us, is that we're going to, we are basically going to be doing perfusion imaging on all patients who present with stroke in our network.
Yeah, we've actually had some phone calls for primary sites that don't do perfusion saying, can I transfer for perfusion imaging? And saying, well, that's crazy. You just need to start doing perfusion imaging. Now that we have this guideline, I think it makes it even more clear that primary centers, if they can do a CTA, they can do a CTP, and then they can pick up this substantial percentage of patients who come in that window and can benefit from IV thrombolysis.
And is that the case also for community hospitals, right? Because we understand primary stroke centers may be better equipped than some of these small community hospitals. Do we have examples of these smaller hospitals also performing perfusion successfully?
There's no reason that they can't. I mean, if it's a really tiny hospital, they may have such a low volume that they don't want to take this on. But then again, you think that these patients are missing out on a beneficial therapy. So I think in general that any hospital that can assess a stroke patient should be able to do CTA and CTP now with these guidelines that are extending out the treatment based on CTP criteria.
So we've implemented it too, Carolina, at like very small hospitals that are sister hospitals that don't have comprehensive capacity. And I think we do get a little pushback in the beginning. but then it always seems to work. So we have a very low volume hospital, and we implemented it, and initially there's a little growing pains, but it definitely worked.
So in addition to the logistics and the low volume of cases, and of course, the more you do something, the better you get at it. So if you're doing perfusion all the time, that's, you're obviously going to be able to get better scans. But there's also the consideration, the financial consideration. So what is the incentive in addition to the guidelines for these sites, for these primary stroke centers and these community hospitals to be doing perfusion?
Yeah, it's a great question. And something that is underappreciated is that there is now a CPT code that reimburses for doing perfusion imaging. So this became active as a permanent CPT code just January 1st. And I don't think the word is out, and it really makes it much, much easier for one of these hospitals to decide to go ahead and bite the bullet and do perfusion imaging. There's a substantial technical fee rate reimbursement for eligible patients, and there's also a 1 RVU payment for physicians who are reading perfusion imaging. So from a financial point, this becomes much more doable for these smaller hospitals to start doing perfusion imaging.
That's great.
Cool, Greg. I didn't actually realize that. And I think previously we were in a world where the primary centers would say, well, what do I get out of this? Like, I'm not getting the DRG for the EVT. We're transferring them to a larger center to get it. But that's good that this is now incentivized financially for the primary centers too.
Yeah, the other advantage, of course, is
we use CTP as a MEVO detector, and I think in many areas where we have EMS-based routing, we have a weird dichotomy where the super simple M1 decisions go straight to comprehensive stroke centers, but probably a lot of the more complicated decisions, the more distal occlusions that are harder to find, that are easier to find on CTP, are actually ending up in primary centers, and no one knows what happens to them.
yeah.
So I've been trying to figure out a way to help that, but this looks like this could do it.
I think the other advantages are the fact that figuring out who has a stroke and who's got a stroke mimic is so much easier for these hospitals. And there's medical legal, obviously, issues if you miss a stroke. Our primary referring centers have been using it for a long time, and it makes it so much easier to decide this patient does or doesn't need to transfer. So they may be able to keep more patients that don't need to transfer, and also be able to treat people faster and more accurately by knowing who does and who is not having a stroke.
So we've got a couple of interesting questions here coming from our attendees here. What are the benefits of doing CT guided thrombolysis versus MRI in late window lytic cases?
So MRI was included in the Extend trial. They started the Extend trial just with MRI, but then since few sites have access to urgent MR, CTP was added, and then the trial was able to enroll much, much faster. So MRI is terrific. It is included within the guidelines to use either MR or CTP for the late window selection.
There's also a question regarding the volume. Do we expect to see an increase in volume of patients who are now able to receive thrombolysis? And then another question also related to CT perfusion, and that is the information about the CTP code something that comes from the organizations? Does it come from at the ministry level, or how do people get informed about this, right? We're getting some requests for that particular slide here from many members of the audience.
I mean, it's a regular CTP code. So there's a billing group for every hospital who is supposed to be up on the CTP codes, but they may need a reminder because, again, this is new and I don't think it has been well publicized. And clearly there will be an increase in IV thrombolysis use with this guideline. Many of the primary hospitals that we worked with, where we had encouraged them to go ahead based on Extend, they said, no, we don't want to do something out of the guidelines. And now here you got the guidelines. So I don't know what the projections are, but I'm sure there will be substantially more thrombolysis given now that we have a much longer time window.
Excellent. Now, there's another question here from the audience, and that is, does aspect score play a role into the late TNK window?
If there's substantial hypodensity, then patients would not be enrolled in these trials, a large area of hypodensity. But the criteria for the extent trial is based on perfusion imaging and mismatch.
Fantastic. I think it's time for us to move on now to Dr. Samaniego's discussion on mechanical thrombectomy. So Edgar, please go ahead.
Yeah, great. Thank you. Thanks, Carolina. Thanks, Greg, for inviting me to present and talk about the updates of mechanical thrombectomy based on American Heart Association guidelines. This is going to be a case-based presentation. These are my disclosures. We're going to present, start with this case of a 74-year-old man who had a seizure, had an NIHSS stroke scale of 17. Last known normal was 3 hours ago, and baseline modified ranking score of 0. So you can see that the aspect looks very favorable, and from the CTA, there is a mid-segment right MCA occlusion. So it's a little bit rare for somebody having a right MCA occlusion to present with seizures. Not completely impossible, but sometimes it's rare. So the question is this really a stroke with a new right MCA occlusion, and therefore should this patient get thrombolysis? And if we go by guidelines, because it's 3 hours from last known normal, he's within the 4.5 hours, he definitely will be a candidate for thrombolysis. But what if this is just, as Greg mentioned, a stroke mimic? What if this is seizure with somebody who has a chronic right MCA occlusion? Therefore, definitely this patient will not be a candidate for thrombolysis. What if he has a tumor that is causing the seizures, and we can even harm him if we give him thrombolysis? So unfortunately, although the aspects was favorable and provide good information, it will not help us in this case in determining if this is indeed a MCA occlusion versus a stroke mimic. So when we see these patients in our ED, we have to face all these different questions. Is this patient eligible for IV thrombolysis? What is the extent of cerebral infarction if he does have a stroke? And if the patient doesn't respond to several intravenous thrombolysis, should we refer the patient for mechanical thrombectomy? So the first question, how should we answer if this patient is eligible for thrombolysis? We have to determine if he has an acute ischemic stroke. We can do it, as Greg said, maybe sometimes with an MRI or an MRA, but unless you're in Japan, where you have a lot of MRIs in most of the centers, this will be cumbersome. Additionally, a lot of patients have contraindications for MRI. They have pacemakers, they're claustrophobic. You have to go through all these checklists for determining if the patient can have an MRI. Therefore, it's not always available and easy to get an MRI. The other option that we have, and is part of our protocol, is doing a CT-ACT perfusion. Same as MRI, will determine the presence of an LVO. If we do a perfusion, we'll determine if there is a core. And sometimes we extend the imaging of the angiographic part of the protocol into the neck to see if there is a tandem. So in this case, definitely I think will help to have CT-ACT perfusion. If this patient were not to be within the early window and is beyond the 4.5 to 24 hours, what can we use to determine the patient will be eligible for intravenous thrombolysis? And in this case, as Greg mentioned, based on extent and some other trials, we can use multimodality imaging with CT-ACT perfusion or MR perfusion to determine if there's the presence of core and mismatch, and therefore determine the patient will benefit from intravenous thrombolysis. Should this patient be referred for mechanical thrombectomy if intravenous thrombolysis does not work? So based on the occlusion, which might be right MCA, he has an NIHSS score of more than 6. He has previous healthy baseline with a modified ranking score of 0 to 1 and aspects of 3 to 10, which is a change in the guidelines because before it was 6 to 10. EBT definitely is recommended in this type of patients. What if the patient was in the late window? It was not within 3 hours, but you're looking at 6 to 24 hours. Definitely, then you have to use multimodality imaging with perfusion to determine the patient has a core, what's the mismatch, and see if the patient will benefit from endovascular therapy. So in this patient, in this case, if we remember, presented within 3 hours, had a right MCA occlusion with seizures. We did a CTA-CT perfusion. There is a small core of 9 mLs with a mismatch volume of 147 mLs. So first, we got several answers from this test that it didn't take 5 minutes. Yes, is a stroke, is not a stroke mimic. Second, has a small core. And third, definitely will benefit from endovascular therapy because there's a huge mismatch. So he got TPA. He got recanalized, was taken to the angio suite. We did mechanical thrombectomy with aspiration and a stent retriever. And in this case, the guideline is very clear. This has been shown by several studies that in patients with acute ischemic stroke with LVO endovascular therapy is recommended. What's new from the guideline is that you can use any technique. You can use contact aspiration, you can use a stent retriever, you can use a combination of both, as long as you get adequate reperfusion. So this is new, and because some studies have shown that there's equipoise between the two approaches. The other thing that's very important to highlight is, like in this case, we did 6 passes because we want to maximize the potential benefit of mechanical thrombectomy. And that's what the guideline says, is evidence 1A, the strongest recommendation from this guideline is that you have to try to achieve a recanalization of TK 2B, 2C, or 3. TK 2A is not good enough because we know that these patients at 90 days might not recover as well as patients who have a more effective recanalization. And that's why, in our practice, and this is even before the guidelines, we try to achieve effective recanalization, and we can do as many passes as we need to try to do that. So that's one case that exemplifies a stroke mimic where CT perfusion was very useful. This is another case. 89-year-old man presents with an NIH of 12, is a wake-up stroke with a good baseline modified Rankin score of 0. Elderly man, 89, with a lot of white matter changes. So it's a little bit challenging to determine what's the aspects. Is this hypodensity here on the back really hypodensity, or is this something old? Is this what we're seeing on the right side, hypodensity? So, we have to address all these questions. Has an NIH of 12? Is this patient eligible for intravenous thrombolysis? So based on the guideline, he is beyond the 4.5 hours. He will go between the late window, 4.5 to 24 hours, because it's a wake-up stroke. So he will definitely benefit from CTA, CT perfusion, or MR perfusion to determine if there is a core and there is a perfusion mismatch. What's the extent of cerebral infarction? It looks like there is an MCA occlusion there on the distal right MCA. So in this case, the extent of infarction is relatively small, with a core of 7 mLs, with mismatch volume of 90, and a mismatch ratio of almost 14. So this patient will definitely benefit for mechanical thrombectomy. So in this case, yes, is a high level of recommendation 2A. These patients, which is within the late window between 6 and 24 hours from last known well, will benefit from mechanical thrombectomy based on the perfusion mismatch that we have seen on the CTA CTP. The other question that we couldn't entertain very well from the CTA, if this is really a distal MCA versus a proximal M2, this makes a difference because the guidelines are a little bit different for MIVOs now that we have 2 RCTs published. So this is, we got lucky, TK3 after 1 pass. You see the occlusion here. It looks like a distal MCA versus a proximal M2, good recanalization. But the question is, and this has created a lot of controversies, because what if this was a non-dominant M2 or a co-dominant M2? And based on the RCTs that have been published, this patient did not benefit from mechanical thrombectomy. And the guidelines state that in patients with acute ischemic stroke and occlusions of the proximal non-dominant or co-dominant division of the M2, MCA, distal MCA, ACA, or PCA, EVT is not recommended to improve functional outcome. Again, I know a lot of centers and a lot of colleagues that disagree with this statement for the guideline, and they are still doing, and we are doing it, mechanical thrombectomy on non-dominant or condominant M2s, because a lot of these patients benefit from therapy. So in this case, CTA, CT perfusion, was very effective in determining the final infarct volume, which you can see on DWI. This is the 24-hour follow-up, which correlated very nicely with the core that was seen on CTA, CT perfusion, and that you can kind of differentiate in the aspects. This is the last case I'm going to show to highlight some of the aspects of the guideline. This case is a 69-year-old woman who presents with an NIH of 16. She's also a wake-up stroke. She had a good baseline functional status with a modified ranking score of 0. Her AXPES is relatively low. As you can see on this non-count CT, there is changes with loss of differentiation between the gray and white matter. Aspects is between 3 and 5. So in these cases, the guidelines are very clear. Selected patients with acute ischemic stroke with an LVO and ICR MCA who present between 6 and 24 hours from onset and are younger than 80 years old with an NIH stroke score more than 6 and a pre-stroke good functional status between 0 and 1 for a modified ranking score, an aspect with 3 and 5. Endovascular therapy is recommended to improve functional outcome. And this is, we have seen multiple, at least 6 RCTs showing this already. That's why the guidelines have this new recommendation. So in this case, CT perfusion was also helpful because, as I said before, aspects sometimes is not very useful. In our practice, we use both aspects and CT perfusion to determine the aspects and also the core. In this case, and the perfusion mismatch, in this case, the infrared core volume was more than 50, so it's a large core. The patient was relatively younger, less than 80 years old, so the patient underwent mechanical thrombectomy. And this is the follow-up 2 years where we see that the patient had craniotomy. And this is also new in the guidelines in patients who are more than 60 years old with unilateral MCA infarction who have deterioration within 48 hours because of brain swelling despite maximal medical therapy. Deep compressive craniotomy with dural expansion is considered. And we have seen, especially in patients with large core, because we're going to treat more and more of these patients based on the latest RCTs, that these patients benefit from craniotomy. So this is the workflow that we have at University of Iowa. We are the only comprehensive stroke center in the state of Iowa, so we get a lot of referrals from spoke centers. Fewer of our patients come through the ED. When they come through the ED, we usually do a CTA, CT perfusion that help us a lot to differentiate real strokes from stroke mimics, determine if there is amoeba, also help us determining what's the core and what's the perfusion mismatch. And then if they don't recanalize and they're within the time window for mechanical thrombectomy, we defer for mechanical thrombectomy after intravenous thrombolysis. A lot of times we get patients who are sent to us from spoke centers through the helicopter. In these cases, if they come or arrive more than 1 hour from symptom onset, we repeat a CTA, CT perfusion to see if there's been any change on initial imaging that was sent to us. If they are within less than 1 hour, 60 minutes from the initial imaging when they were sent to us, they go directly to the angio suite for mechanical thrombectomy. We do late window patients up to 24 hours, but we rely heavily on aspects and CT perfusion for deciding if these patients might benefit from mechanical thrombectomy. We also do a lot of MIVOs, but we base our MIVO selection based on the location of the MIVO, the age, the eloquence, and we use the CT perfusion to determine where is the MIVO. And also we use large core and we use aspects and CT perfusion for determining if the patient might benefit from thrombectomy. So to summarize in what relates to mechanical thrombectomy and the new guidelines, we have the within 4.5 hours for intravenous thrombolysis and within 6 hours for EBT. Based on the new guidelines, you can mainly use aspects. However, I do think that CT perfusion, CTA are very beneficial in choosing patients with stroke mimics, choosing patients with MIVOs, and also selecting patients for large core. When you go into the extended time window, which will be for intravenous thrombolysis, more than 4.5 hours or more than 6 hours for EBT, the new guidelines recommend the use of perfusion imaging. For procedural aspects of endovascular therapy, the proceduralists can use the technique that they are more comfortable as long as they achieve a really good reperfusion with TT2, B, C, or 3. And finally, something that a lot of people in the community do not agree with is the recommendation of MIVOs, especially the codominant or non-dominant M2s. So I'm happy to answer questions or discuss with the panel some of the cases that I presented.
Thank you so much, Edgar. Great presentation. We do have a question here from one of our attendees regarding the second patient you presented. And the question is, so will this second patient actually receive TNK? Is this a candidate?
Yes, we have embraced the IV thrombolysis beyond 4.5 hours. We have been doing that even before the guidelines were published, based on the studies that have been published before, and the patient did receive TNK, IV TPA. The other thing that we have seen is TNK appears to be a little bit more effective at intravenous thrombolysis with TTA. And some of these patients do recanalize even if they have LVOs. So that's something that is interesting that we have seen, because most of the centers in the state of Iowa have switched from TPA to TNK.
Mm-hmm. Got it.
So, Edgar, thanks for including your workflow, because I think with this guideline, there may be a tendency for people out there to say, oh, okay, so, because there's still some centers that I don't think it's correct, but they do CTP only after 6 hours. And now there may be centers that are saying, oh, so now we do it after 4.5 hours. And I like that you showed your workflow is that you do it on every patient inside of 4.5. And that's what we do too. And that's what I really advocate. And the point here is we've talked about a little bit is it's not just core versus penumbra. It's, as Greg was saying earlier, it's the mimics. It's MEVO detection, which is very important, whether or not you're intervening on them. It helps you determine the chronicity of a lesion. If someone has just a big swath of Tmax greater than 4 and a low stroke scale, I may be thinking more ICAD than like an acute, embolic occlusion. And I think probably most important is actually what we don't talk about is like the reliable technical execution. So if you have your techs doing it sometimes but not all the time, then they're just not practicing, and they're practicing two different pathways. So I think it's really important. And I wrote a review with David Labuskin in MedLic Neurology where we basically really suggested that people do perfusion on everybody and not try to pick and choose who you're doing it on. It's also, you really don't want to be in that situation where you do it on somebody because you only do it in the late time window and you thought they were early, and then it turns out that, oh, they actually woke up with the symptoms and you don't have a CTP, and now you got to send them back. So we do what you do in your workflow, and we do it on every patient.
So we've got a couple of questions here from the audience related to the CTP. And one is, and I think you touched upon this as well, can CTP help determine if an occlusion is chronic? And when you do CTP in the early window, are you worried that there might be a ghost score?
So ghost score for early window, you use a different threshold. So rather than the 30% RCBF, you use a 20%, and that essentially eliminates the ghost core. You can also, in patients who've already had reperfusion, you may miss the core, but you will see it on the non-contrast CT. And I wanted to comment a little bit on the fact that although the guidelines are emphasizing aspects, there are some limitations that are important, and I think more that we can get out of a non-con CT than just the aspect score. What we've seen for these trials is that these patients came in typically aspects 3 to 5. Some of these patients have very subtle changes, which we call low net water uptake, and some have very severe hypodensity. And not only the prognosis, but the response to EVT seems to be quite different. If you look at the patients who you can see a very dark lesion, these patients are the high net water uptake. These patients have injury to the blood-brain barrier, and we see they do very poorly with or without EVT, whereas it's really the milder aspects changes are the ones where we saw the big advantages. And there was even a study from the SELECT-2 that looked at just, rather than assessing net water uptake, just look at how severe the hypodensity is. And if the hypodensity was less than 26 Hounsfield units, it was considered very dark. You add up those voxels, and if you get to 26 ml, it neutralized the benefit, suggesting that going beyond mass specs may be able to show us some patients who really don't benefit. This can now be done in an automated way with AI software. This was presented at ISC. And what you can see is that if you look on the x-axis with these core volume that's very dark, less than 26 Hounsfield unit, there's a dramatic relationship between good outcome, shown on the y-axis, and how much hypodensity you have, such that if it's very substantial, they actually had a trend toward worse outcomes. So I think we need to go further. And as Edgar mentioned, there's really a benefit in looking at both the core with CTP or MR. This was from a pooled analysis of all 6 of the big trials, showing that as the core went over 150, regardless of the aspect score, you had no benefit that could be seen. Wide confidence intervals, so we need more data. And we've also seen, even in early window, we were saying about should we do early window advanced imaging from the French, the last trial, as well as Angel Aspects, just published over the last couple months, shows that even in the early window, if there is no mismatch, they saw no trend toward benefit, and even in Angel Aspects, a little bit of a trend toward no benefit. So again, suggesting that early window, this imaging may be very helpful for us to guide which patients should not get thrombectomy. We're starting a big trial called Outer Limits now, which is really trying to explore some of these issues like the net water uptake, severe hypodensity, and how big a core is going to benefit, trying to get a little bit more sophisticated than just the aspects approach.
And that's great. That actually addressed one of the questions that we had from the audience, which was, what is the recommendation regarding core size and penumbra size, given the results of the large core trials and the fact that very few patients had truly large cores in those?
There was a lot of selection bias. We could see no mismatch patients are very common in the late window with large core. Virtually none were enrolled. And even these really large cores, you had to add up all 6 trials to get 150 patients with very large cores. So in our pilot work with Outer Limits, we've seen that there are patients coming in with 250 cores. And these are just patients where we don't have randomized data yet.
And I'll give you the Tesla perspective, which is, Tesla is kind of touted as a trial that did not use perfusion imaging, but of course it was conducted, your inclusion criterion was purely aspects, but, and I'm going to talk about MEVO and how people were cherry-picked in the MEVO trials, but we cherry-picked in the Tesla trial. So we didn't, if someone had a match deficit, we did not enroll them. In my site, we were not trying to prove that match deficits benefited from reperfusion. That's kind of ridiculous. So, it would have been nice, to see some perfusion making it into the guidelines around large core, but maybe that'll be on the next round.
There's one final question before we move on to your presentation, Jason, and that's for the whole panel. Do we really want to do perfusion on every patient? Are there concerns about radiation dose?
Well, I saw the comment there. I mean, their comment is, the question is there a concern with radiation dose if CTA and CTP are being repeated if shipped? Oh. And I would say, think about that for a second. That means that you have a patient in a center where you have an immediate, everything we know that time is brain with stroke. We're going to actually wait a couple of hours until they get shipped to us to get that imaging. They could be a candidate for delayed thrombolysis. So we often don't repeat it. We try to expedite transfers. But I think with respect to the specific question, look, you have them in a place where they can benefit from a treatment. We know that actually we published a study showing that in our patient population, being transferred, you're 5 times more likely to end up disabled or dead when you get your EVT. So you're already kind of against the wall. I think giving them the treatment at the initial hospital they present makes a lot of sense.
I think that another comment on that is that I think the risk benefit of getting a little bit more radiation and contrast is better in terms of not missing a stroke mimic or not missing somebody with underlying ICAD or somebody who has a chronic carotid occlusion that will definitely guide your therapy. So I definitely can justify doing an extra CTA or a CT perfusion to try to characterize what's the stroke mechanism, what strategy we're going to have for treating this patient.
Great. So with that, we're going to move on now to Dr. Tarpley's presentation. Please go ahead, Jason.
Great. Well, thanks, Greg and Carolina, for the invitation. So I'm going to talk a little bit about MeVO EVT guidelines, but really I'm going to talk about the data and where I think we are, and kind of how it relates to the guidelines. There's my disclosures. So it's no, it's no surprise. Everybody knows about the MeVO trials in 2025, which were neutral. That included escape MeVO, distal, and discount. And I think these are super important results, but we have to ask who they really apply to. And I think people know there was a lack of equipoise for proximal MeVOs, for M2s, and severe stroke scales. And so we ended up enrolling a lot of very distal occlusions. I was a part of escape MeVO, but this was the case in distal and discounts too. Very distal occlusions and lots of patients with low stroke scales. And in this selected group of patients with distal occlusions and low stroke scales, having a neutral result really means that some benefit and some are harmed. And, ongoing clinical trials are going to help us understand that. But also as experts, we have to try to take some of the onus on ourselves to figure out who are those who are benefited and who are those who are harmed. So I'm going to show you some data showing EVT benefit in very early presenters and likely harm in late presenters. EVT benefit in higher stroke scales and harm for those with low stroke scales, and EVT benefit in patients who have large Tmax greater than 6 seconds areas, and harm for those with small perfusion defects. So first of all, to address the equipoise problem, at Providence, we have 52 hospitals across 6 states and many comprehensive stroke centers that are high performing, and actually several of them enrolled in escape MeVO. So we actually compared our patient population to those of escape MeVO. In this first graph here on the left, it's true. We generally, the MeVOs that we treated were younger, with a median age of 72 compared to 75. But I think the more important comparisons are in this green box here. So you can see this distribution of Providence MeVOs really had much higher stroke scales than the ones that we enrolled in the trial. So we had a median of 12 as the stroke scale median, compared with 8 in escape MeVO, and that was a statistically significant difference. And likewise, there were less M2s in escape MeVO. So escape MeVO had only 43% M2s, whereas the Providence MeVO population had 80%, and chi-square showed that to be statistically significant as well. So we really were treating patients in these trials who don't really represent the standard MeVOs that we see. They're really very distal and low stroke scales. These are the stroke scales for distal, escape MeVO, and discount, a median of 6, 7 to 8, and 8. And I know you guys know what a median is, but I just have to repeat it because I think when you say it out loud, it's a little bit flabbergasting that half of the patients that were enrolled in distal had a stroke scale less than 6. And so, the natural history of a patient with a stroke scale that's less than 6 is actually going to be very good and really does not warrant putting a catheter into their brain. It doesn't mean that MeVOs don't benefit, but these ones with really low stroke scales in these trials certainly did not. These lesion locations of these trials were also very distal. So not really M2s, but in the distal trial here in the panel A, you can see 53% of the lesions, the vast majority, were beyond the Sylvian point here. In the discount trial, fully 100% of the lesions had to be above the mid-height of the insula on a coronal view. So these lesion, these locations here are all M2s that would have been treated outside of the trial, and not all of them are dominant M2s. And then likewise in escape mevo, the largest group that is represented are these M3s that are way out here, right at the area of the Sylvian point. So as I said, neutral results. That means some patients benefit, some patients are harmed. In escape mevo, we saw an early signal with respect to time. So patients who were treated late, greater than 260 minutes, had a trend towards harm, whereas patients who were treated early had a trend towards benefit. And actually, this distal signal showed that patients who were these very distal low stroke scale patients, those who had a stroke scale less than or equal to 5, seemed to have a trend towards harm, and those who had a stroke scale greater than 9 had a trend towards benefit. So a little more granularity on that. This is the escape mevo data shared by my friend Michael Hill. And patients who are really quite early, you can see there's a profound modification by time, whereby the outcome was much better for endovascular therapy and usual care if they were treated with endovascular therapy ultra early, and actually you see harm in the late window. This gave rise to the idea that these very distal mevos act more like end arteries that seem to progress more rapidly than proximal occlusions. This is data from Mario Psychagios, who showed that if you actually take the distal population who had higher stroke scales, but also layer in a perfusion threshold of Tmax greater than 6 of at least 34 milliliters, then you would get a positive trial when you consider those two variables. So this has led really to what we do, which is a more nuanced approach of treating these very distal occlusions, considering the high stroke scales, the really early time windows, and a favorable perfusion profile when we're deciding whether or not to intervene on them. And I think that this nuance wasn't really encapsulated by the latest guideline. And then furthermore, now we have Oriental Mevo. So Oriental Mevo was presented at ISC this year, and basically only enrolled patients who had a stroke scale over 6. So that was the main difference compared to the other trials. They had to be greater than or equal to 6, and the median stroke scale was 10. So when you enrolled patients with more severe neurological deficits, lo and behold, you got a positive trial. And so that brings us to the guidelines. So Edgar mentioned this. We have a class 3 no benefit guideline around acute ischemic stroke for proximal non-dominant or co-dominant division proximal M2 segment of the MCA, and also distal MCA, ACA, PCA. So EVT not recommended to improve functional outcomes. And so I have some issues with this guideline. I think it's a little bit of a luminography-centric MEVO EVT guideline, right? It's basically saying if you have an M2, unless it's dominant, which is defined in the guidelines as greater than 50% of the vascular territory of the MCA, then it's not recommended. But I make the argument that the trials of 2025 really included mostly occlusions that were other than M2. So whether it's a dominant M2 or a non-dominant M2, most of those patients were not in. There's no mention of perfusion imaging in the guidelines, despite the fact that, you've now heard from 3 different people that perfusion helps predict who's going to be benefited and who's going to be harmed. And in a complicated situation like determining whether to do an intervention on a MEVO, that's more important than anywhere. There's no mention of time, despite the benefit that is realized by patients who present really early. The enrolled patients were clearly cherry-picked for low stroke scales, but yet there's no mention of NIHSS in the guidelines. And now we have Oriental MEVO, which corroborates that their patients who have higher stroke scales are quite likely to benefit. And so I think these guidelines are in need of refreshing. Although I applaud the authors because they put a lot of hard work into it. but I'm being controversial a little bit on purpose. So here's a case example, MB. This is an 81-year-old, really highly functioning lady, paroxysmal AFib. She actually had it detected on her Apple Watch and was waiting in the cardiologist's office to ask what to do about it when she suddenly stopped talking. She presented to us in the golden hour. So her last known well time was noon, and she got to our ER at 12:29 with mute global aphasia and a stroke scale of 10, which you can see over there to the right. Her non-con head CT showed an aspects of 10, not surprisingly, and her CTA showed a superior division occlusion right at the mid height of the insula. Her CTP showed 38 cc's of Tmax greater than 6. This is her CTP, and I'm not too concerned. Greg said this is inside of 6 hours, so we could use a different CBF threshold. I think this is quite possibly ghost core when I see something like this early, and yet we have a 38 cc Tmax greater than 6 swath. So the patient was given IV TNK, and according to the AHA guidelines, we should stop there. However, according to the nuanced approach, she's early. She has a high stroke scale of 10, right at the median for Oriental Mevo, and she has a large perfusion defect. So we took her emergently for catheter angiography, and we see here the same thing we saw in the CTA, which is this occlusion right at the midpoint of the insula. And after one pass of suction thrombectomy, got TICI-3 reperfusion. Upon doing that, the patient, who was previously mute, perked up and said, "I think I'm okay now." Here is her MRI, which matches her clinical course. There was only this tiny punctate area of stroke, and her stroke scale was 0, and she was actually discharged to home on postoperative day 1. So in summary, the neutral trial, EVT trials of 2025 had lack of equipoise, but they are really important. They tell us what to do on these very distal occlusions with low stroke scales. I told you that there's some highly selected group of patients who seem to be benefited versus harmed. Now we have Oriental Mevo, which corroborates that, maybe we should be intervening or at least enrolling in a clinical trial if patient's stroke scale is significant. And luckily, we have clinical trials, including DUSK and STEP, which are currently enrolling and will help address this issue.
Fantastic. Thank you so much, Jason. Great presentation. So what do you say to people who may argue that, doing more CT perfusion doesn't necessarily need to more EVT, that it actually will help with thrombolysis only? What's been the experience at your site?
Okay, so I'll share again. We have specifically looked at this. And in fact, I'm just one stroke director at Providence, right? So we have 52 hospitals. That means 52 stroke directors. And it turns out that inside the first 6 hours, about half of the centers do CTP on everybody, and about half the centers save it for those who are outside of 6 hours. And so we actually looked at this and said, okay, in our 13,000 patient cohort over, from 2018 to 2024, we had 57%, 7,800 of them got CTA only, and 5,900, 43%, got both CTA and CTP. And so this enabled us to say, what does doing a CTP mean in terms of EVT? Is it ruling patients out? Is it ruling patients in? And so what we saw is actually, if you get a CTP, you're actually more than twice as likely to get endovascular therapy. And so usually I ask people, what do you think the rate of EVT is in all acute ischemic stroke? And usually people say around 15%, which is true, because it's 8% if you're just doing a CTA, and it's 20% if you're doing both CTA and CTP. And it actually increases overall the degree of the amount of EVT that you do. So you do more EVT if you do a CTP on patients. And I think some endovascular people are worried that they're not going to get to do their thrombectomies if they do CTP. But actually the opposite is true. And in fact, with respect to MEVOs, you're 3 times more likely to get endovascular therapy for if you do CTP than if you don't. Now, I'm not saying that everyone should get a CTP, but I think you really need to know. I'm not saying that every MEVO should get an EVT, but if you don't do CTP on everyone, you're not gonna find a lot. And just adding a couple things, I know you guys want to address some more questions, but there will be people who say that it takes more time. We looked at this in this massive data set, and in fact, the door-to-needle times were slightly faster in all of the patients who got a CTP, and the door-to-puncture times were also faster. And so if it's done well and it's practiced, it really shouldn't cost you any extra time. And I'll just say this is why doing a MEVO, finding a MEVO on a CTA is like finding a needle in a haystack. That's why I'm pointing it out to you with this blue arrow. This is a distal occlusion right about the midpoint of the insula that pop right there where it turns yellow. It goes away. It's really hard to see. This was in a patient who had a significant stroke scale, so I ended up doing endovascular therapy. And this is what it looks like on a CTP. So this is very easy to detect, and that's why we see about 3 times as many MEVO EVTs when we do a CTP.
Thanks so much, Jason. And I want to open it up now to the panelists. We covered an enormous amount of material today, and the hour just flew by. But I wanted to give everybody an opportunity for some closing words before we wrap up.
I can talk about the endovascular aspects of the new guidelines. I think that the most important message is strive for excellence in trying to recanalize. We know that the new target is TK2C, TK2B, and TK3. If we're gonna do mechanical thrombectomy, you have to choose very well our patients. And I do think that if you are practicing the 21st century and you have the tools to choose patients based on CTA, CT perfusion, might as well use them. If your center has the capacity to have those, we use those all the time on top of aspects. So it's a multi-dimensional selection of patients based on imaging.
Thank you so much, Edgar. And Greg, final words here, including, I'm going to leave it with one question that has come up multiple times here from our audiences. Do you do CT perfusion before a CTA?
Yeah, we do. And I tried to answer as many of these questions as I could during these talks, but thanks to the audience for phenomenally good questions. The reason we do it first is because we're going to get it out faster. And then typically even before the pharmacist is there with the TNK and we've determined that they're TNK eligible, we have the CT perfusion. So we can see, does this look like a mimic, right? And so we find it to be more useful than the CTA, so we'd rather get it first. It's basically going to tell us what we're going to see on the CTA. The CTA will tell us exactly where the occlusion is, but the CTP tells us whether we do or don't have a vessel occlusion.
Fantastic. Well, I would like to thank our audience here and just want to tell everybody, I really appreciate you all joining us. I want to especially thank our phenomenal expert panelists here. Great presentations, great discussion. Many people have asked, can we get this information again? Yes, you can. For everybody who's registered, you will get a follow-up email. You're able to go to the rapidai.com continue and you'll have access to the presentation there. So thank you again for joining us and have a wonderful rest of your day. Take care, everybody.
Thanks, guys.
Thanks.